Hello, my name is Mariya Miteva. I'm going to talk about trichoscopy of non-scarring alopecia. Non-scarring alopecia differs from scarring alopecia by the absence of follicular scarring. So you can see on one side the hairs organized in follicular units, and on the other side you can see areas where the follicular units are absent. In the biopsy, that presents as fibrotic tracts. I'm going to cover the most common non-scarring alopecias: diffuse non-scarring alopecia, Telogen effluvium, androgenetic alopecia, alopecia areata incognito, and I'm not going to talk about hair shaft disorders because that's a large topic on its own. But you're welcome to review our paper from the Journal of American Academy of Dermatology on that topic. I'm going to talk a little bit about patchy non-scarring alopecia such as alopecia areata and trichotillomania. So what are the specifics of trichoscopy? You can use any dermatoscope or video dermatoscope to perform trichoscopy. In the clinic, we usually use the video dermatoscope when we want to take and store pictures. You can start the trichoscopy with contact, non-polarized light without immersion. So we use immersion fluid when we want to visualize better the surface, look at the vessels, but we start without fluid because we would want to be able to look at the scaly and keratotic conditions on the scalp. Vessels are better seen with non-contact polarized light because the polarized light cancels the reflections from the stratum corneum and you can see better the dermal processes. Most published trichoscopy work comes from video dermoscopy with immersion fluid. So what about normal scalp? In the scalp, the hair is organized, as you see, in follicular units, in groups. Usually about 70% are organized in groups of 2 and 3 hairs. About up to 20% are thinner hairs. The rest are thick hairs. And remember that the temporal areas in women have lower hair density. What about Telogen effluvium? And Telogen effluvium is very common in the hair practice. Usually patients have full head of hair, but they're shedding more. And you can see here on trichoscopy that we don't have specific features, but we don't see hair shaft variability. So the hairs look uniform, they're organized in groups. We can see short regrowing hairs, and you can see some empty dots, which are actually the openings of the follicles without hair shafts. On biopsy, the picture looks like normal scalp. This is a normal distribution of the follicular units organized with their sebaceous glands. There is no hair shaft variability because the terminal to vellus ratio in this case is, for example, 7:1, which is normal, and we have normal telogen count. In alopecia areata, you know this is a condition that goes through stages. In the acute stage, when the patient sees the patch and the patch is just of recent onset, patients usually have also a lot of shedding. You can see these yellow dots and you can see black dots and broken hairs. What are the yellow dots? These are the infundibula plaqued with sebum and keratin. They're not visible in Fitzpatrick skin types 4 to 6. Keep that in mind. In the subacute stage, the patch is still there. Patients may still be shedding. The condition continues without resolution. You can see broken hairs and black dots. I will talk about dystrophic hairs on the next slides. And in the regrowth stage, we see these circle hairs, which look like pigtails hairs. They're a type of short regrowing hair. In chronic stage alopecia areata, we see yellow dots without regrowth. So these are examples of dystrophic hairs. They could be black dots when the fracture in the affected hair shaft occurs prior to exiting the scalp, or they can be broken hairs where the fracture occurs after exiting the scalp. Exclamation hairs come from the resemblance to exclamation mark, and they're considered specific for alopecia areata. You can see on biopsies that the dystrophic hairs actually correspond to follicles affected by the loss of the immune privilege and the presence of this lymphocytic infiltrate that invades the bulbs, the matrix of the follicles, and resembles the swarm of bees infiltrate. These are examples of regrowing hairs. We have upright short regrowing hairs, and we have circle hairs, which correspond to vellus follicles, intermediate-sized terminal anagen follicles, and patches with recovery. Keep in mind something important. In prepubertal children and in adults after the menopause or andropause, the sebaceous glands are atrophic or hypoplastic, so they are not able to fill the infundibulum with yellow sebum. Therefore, the yellow dots may be absent, and this could be a common mistake to call this scarring alopecia because of the absence of yellow dots. In alopecia areata incognito, which is characterized by diffuse abrupt shedding, you can see here that there are no specific features. But before we see yellow dots, before treatment, some yellow dots, some short regrowing hairs, and after that we see improved hair density. And this is important. You can show the patients how they can appreciate the improvement on their own. In androgenetic alopecia, which is the most common condition in the hair clinic, the main feature is hair shaft variability. There is follicular miniaturization. The terminal to vellus ratio is less than 2.2 to 1 because we have predominance of vellus or thin hairs. And you can see here that there is a clear hair shaft variability on dermoscopy. We have yellow dots. We can have that in androgenetic alopecia as well. It's not a specific feature for alopecia areata. We have vellus hairs, which correspond to these thinner hair shafts. Some intermediate hairs, meaning that the diameter is between vellus and terminal hair. And we have also single terminal hairs. So this is the main feature, hair shaft variability. There is increased number of follicular units with single hairs in the frontal scalp in androgenetic alopecia. What about trichotillomania? Trichotillomania is characterized by hairs broken at different lengths. And you can see this seminal paper on trichotillomania describing the different type of broken hairs. And this is an example. So we have hairs broken at different lengths. We have coiled hair, flame hair, looks like a flame, broken hair with clean tip. And then we have also some circle hairs here. Look at the coiled hair. It does look like a question mark. And we have black dots, which are types of broken hairs, as we discussed. Tulip hair is where the tip is a little bit darker. On biopsy, they correspond to this distorted hair shafts in the follicular canals, trichomalacia, with a drop of the pigment from the cortex in the follicular canal called pigmented casts. Don't mistake that with Tinea capitis because Tinea capitis is really easy to distinguish on dermoscopy if you identify the comma hair. Comma hair is considered specific for Tinea capitis. Thank you very much for your attention.